Next, Dolph Hutter and Dr. Mark Sherrid, the director of the hypertrophic cardiomyopathy program at Roosevelt Hospital at Columbia University in New York, discussed the differential diagnosis of hypertrophic cardiomyopathy versus the athlete's heart, echocardiographic pearls.
I'm Dolph Hutter. First of all, Mark, thank you for joining us.
It's a pleasure.
This is a common problem. I personally have been involved with athletic heart problems for a long time, and we always run into these gray zones. Tell us a little bit, what kind of person, what kind of training, and what type of training do you need to do in order to get into this diagnostic problem?
First of all, thickening of the heart happens with endurance athletes less than it does with strength athletes. The weightlifters, the football players, they'll have the thickest hearts that we'll see, while patients or individuals who are runners and endurance athletes, their hearts will tend to thicken to a lesser degree, but they'll dilate to a greater degree.
Right. And the interesting thing, they both increase their cardiac mass, but as you said, by different geography. Now, the thick hearts is where we have the problem between what's normal thickness and what's pathological. Right. How long does it take to develop a thick heart in an athlete? We're not talking about our casual athlete, are we?
So these are competitive athletes. These are athletes who are engaged in rigorous training programs, often many, many hours per week. This is not a phenomenon that occurs in the weekend warrior.
And I guess we could just throw in that it occurs with more training, the more likely you're going to develop these changes.
Absolutely.
Now, let's say we have a highly competitive athlete and somebody has a wall thickness, and the question is raised, is this physiologic or is this pathologic? How do you make the decision?
Generally, wall thicknesses greater than 16 millimeters on an echocardiogram will indicate that a patient has HCM as opposed to athlete's heart.
Okay. And that's indexed for size too, or it does adjust for size, is that right?
Well, in the large study performed on very large football players, the highest wall thicknesses that they measured in that study was 16 millimeters. Yeah. So the larger the individual, the greater the wall thickening, but generally 16 millimeters.
Well, of course, a soccer player would be more of an endurance athlete, so that's really not, but a weightlifter, a wrestler, or something like that, you might account a little bit for the size there. Now, in addition to thickness, what other characteristics do you look for in the echocardiogram as you're making a decision?
Patients with HCM will have smaller LV cavities as opposed to the endurance athlete or the athlete in general who will have larger, more dilated LV cavities. So the presence of an LV less than or equal to 55 millimeters would indicate the presence of hypertrophic cardiomyopathy.
In diastole. Yes. So wall thickness over 16 and diastolic less than 45, that raises your eyebrows.
Right.
Any other echo studies that you would do?
Yes, we'd also look at flow Doppler across the mitral valve, looking for impaired relaxation, characterized by a low EA ratio and by decreased deceleration of the E wave in early diastole, because these are findings that would be abnormal in patients with HCM, but normal in athletes. However, presence of normal flow Doppler would not rule out HCM, but the presence of abnormal diastolic function, as I've mentioned earlier, would indicate HCM.
Or go along with it,
yes.
Because we did some studies in the Harvard players, and we found that do decrease the diastolic function a little bit, which goes away with detraining, which we can get into later on. So flow Doppler for diastolic, do you use tissue Doppler, or do you need to? Or?
Tissue Doppler is very helpful. However, it's important to recognize that different machines acquire tissue Doppler differently, and patients performed on one machine will have a different diastolic tissue velocity performed on another machine. In general, spectral Doppler, tissue Doppler is higher by about 25% than color tissue Doppler measurements.
So you have to know your machine. And it sounds to me like you got to be pretty experienced in reading these things.
Yes. You have to have looked at a lot of normals.
Now, anything else you look for in terms of anatomy to help you make the diagnosis?
We also look at whether there's systolic anterior motion of the mitral valve and whether the mitral leaflets are long, because sometimes this occurs in HCM even when the walls are not very thick. And if this occurs, SAM occurs, and especially if there's mitral septal contact, either at rest or with exercise, we will diagnose hypertrophic cardiomyopathy.
Let me ask you about the rest versus exercise. Do you think rest and Valsalva is good enough to look for SAM, or would you want to do an exercise?
We do exercise echoes on all of these patients.
And do you pick up a lot of SAM with
Yes.
exercise that you don't see at rest?
Absolutely.
Well, that's very helpful. So if you've got greater than 16 thick, less than 55 diameter, diastolic dysfunction, and SAM, you've got it. Is that right?
The patient has a diagnosis of hypertrophic cardiomyopathy.
Do you think those criteria with echocardiography is enough for you to tell a person to whom athletes is very important, say a college scholarship or professional, that he can't play?
Well, moreover, Dolph, I think that if an individual has only one or even two of those items on the list, they might be disqualified, and wall thickness greater than 16. So you don't have to have SAM. You don't have to have diastolic dysfunction. If you have a wall thickness of 18,
Sure.
This doesn't occur really.
In a small left ventricle. Yeah. But you think an echo itself, well-read echo by people who know what they're doing, allows you to make a good diagnosis of hypertrophic.
Yes.
Now, what about detraining? We all get these gray zone cases. Tell us about the effects of detraining on wall thickness in a normal heart versus a Holcomb heart.
Well, if after consideration and thought, it looks as though there's still ambiguity, then we would advise stopping training for a period of 3 months and repeating the study.
And they usually go down if they're normal, physiologic, and they don't go down if they're pathological.
Exactly.
How about the role of MRI? Do you think it helps? When do you use it?
I think it can be very useful. Since these decisions are often heavily freighted, and since there's always a large emotional component in these individuals who have athletics as an important part of their life, they're going to want a full workup.
Yeah.
And we do an MRI, and we look at the wall thickness, and we look at delayed gadolinium hyperenhancement, looking for any sign of scar.
And do you very frequently find the MRI showing you something that you didn't see on the echo?
Not really.
Not too often.
Not too often. We'll use them as confirmation, and we'll compare the studies side by side, and this often leads to an additional level of comfort among the patients to see that with 2 imaging tests.
And you made another important point, and that is you will compare the studies. You can't just read the report. You got to look at the studies. We all know there are technical aspects to interpreting both MRIs and echoes. So you look at the studies yourself, and they're not adequate, you get a good one done.
Well, more importantly, cardiac MR is still at a young stage. And there are places that are not experienced at reading them, and we have to look at our studies ourselves to make sure that the wall thicknesses are accurately measured.
Mark, thank you very much. That's a very thorough and succinct description of how we can make a decision in these tough problems.
It's a pleasure.